Thank you to the steering committee for inviting me today. And I'm a board-certified dermatologist, and I practice just down the street. But the way I got involved with transplant patients and volunteering with transplant patients is basically as a resident. As Shar had mentioned, you can see how valuable the gift of a transplant is. And it's a shame sometimes that things as simple as skin cancers can impact the quality of life with patients with transplant patients. So that's primarily how I got involved. Now, I guess one question for the general audience is, do you know what the most common cancer is after you've received a transplant? Exactly. That's why I'm here today, because skin cancer is the most common cancer following transplant. So just some disclosures, I don't have any pharmaceutical company affiliations. I've done some consulting for Google before. I was a prior faculty at UCSF before joining Communal Medical Group, where I practice. And in today's educational program, essentially what I like to do is take a step back and review some of the basic clinical appearances of common skin cancers and and explain how this relates to transplant patients with regards to how common is it in transplant patients, what are the risk factors, how do you prevent this, and then how do you treat it. Now, the steering committee has also given me a list of questions, just unrelated topics, but topics relevant to kidney transplant patients. So I'll also spend a few minutes answering some of those questions, and then in particular things about itch, shingles vaccine, and then I'll open the floor up for a general Q&A. And just to highlight the fact that skin cancer is a problem, you all probably picked up one of these BAAKP flyer earlier today over here. There are 3 articles just within this newsletter all about skin cancer, or patients describing their experience with skin cancer. So definitely it does happen, and I would encourage you to go ahead and take a look at this. Okay. So the appearance of skin cancers. Okay. So skin cancer is the most common occurring skin cancer in general. So it makes up about 1 out of every 3 diagnoses of cancer in the United States. And generally from the skin cancer standpoint, we divide them into melanoma and non-melanoma skin cancer. Melanoma is a cancer of the pigment-producing cells. The pigment is called melanin, and clinically these are brown or black skin lesions with typically abnormal color, border, or symmetry. Even though melanoma only makes up about 4% of our diagnosis, it makes up about 70% of the deaths associated with skin cancer in the general population, so it's very important to recognize. Again, the same information down there. Okay. Non-melanoma skin cancer is the most common form of skin cancer, and these are over 1 million cases occur in the U.S. each year. The most common skin cancer in the general population is basal cell carcinoma. Squamous cell carcinoma makes up about 16%, and then others, including a rare cancer called Kaposi sarcoma, makes up about 4%. So what do basal cell carcinomas look like? These are these red, sort of waxy pink bumps. Oftentimes people will say, "Doc, it looked like a pimple that just never went away." They'll often have a central depression and sometimes will bleed. Now, these are locally invasive and rarely go elsewhere in the body. This is an example of a basal cell carcinoma that was untreated for around 15 or 16 years. So while it can be locally invasive, if it's untreated, it can certainly cause significant damage. And this is just a picture of what it looks like underneath the microscope. Okay? Squamous cell carcinoma is a second form of non-melanoma skin cancer. It's the second most common form of non-melanoma skin cancer in the general population. And these can look like thick red or dull red scaly skin lesions, and they're very common on sun-exposed areas such as the head, the neck, the ears, the lips, the back of the hands, and the forearms. Now, these can be more invasive than basal cell carcinoma, and so in rare cases, 1 or 2% in the general population, they can travel to other distant organs or metastasize. Again, an example of a squamous cell carcinoma that went untreated for many years. Okay. Now, the good thing about squamous cell carcinoma is that there are some precursor skin lesions, so you can recognize if you're susceptible for developing them. And these are called actinic keratoses. And clinically, these look very much like what you see in this picture, an area of white scale that occurs on sun-exposed areas of the skin. About 1% of these lesions can develop into a squamous cell carcinoma. And typically, a keratinocyte refers to a normal skin cell. UV radiation in the form of sunlight will usually be exposed to these skin cells, and over a period of 15 or 20 years, these cells will actually develop abnormalities, genetic abnormalities, which predispose them for becoming a skin cancer. And so eventually, about 1% of these, or less than 1%, will develop into a skin cancer. So if you have these, they should be treated. If you notice on these areas where these patients had skin cancers, all around them are these scaly lesions called actinic keratosis or precancers. So certainly this patient not only has an active skin cancer, but also many different precancers surrounding it. Now here's a rare type of cancer, and the reason why it's important is because it can and does occur in transplant patients, and it's called Kaposi sarcoma. And these are cancer of the blood vessel cells, and there are various pictures, and this is a very large tumor. Clinically, most commonly, they look like bruise-like lesions, and they're caused by a virus called human herpes virus 8. And these can occur in transplant patients, although rarely, but at much higher incidence than the general populations. Now, Kaposi sarcoma generated notoriety in the 80s because it developed quite frequently in HIV-positive patients, while it may generate or occur in transplant patients. It has nothing to do with the HIV virus. It simply has to do with being immunosuppressed. There are different forms. There are skin-related, and then there are internal forms. It's actually the most common transplant populations which generates these are the pediatric transplant patients. And this is an example of Kaposi sarcoma which occurred in a transplant patient, and it looks like sort of this brown discoloration which developed on this patient's foot. He also generated larger tumor-sized lesions in this area. Okay, so that's a broad overview of the different types of skin cancers that we generally see. Now, how does this relate to you? Well, there are over 140,000 patients in the U.S. that have had a transplant, and greater than 25,000 transplants are performed annually in the United States. Kidney, as many of you may know, is the most common, but also many other organs are transplanted nowadays. And so what are your chances of getting skin cancer? And it turns out in transplant patients, the risk of developing skin cancer increases each year after your transplant. So that, say for instance, at 5 years, some studies have shown 6% of kidney transplant patients develop skin cancer. At 10 years, that number has doubled. So each year out from your transplant date, your risk increases. As transplant recipients are living longer, because of the technology, the medications, then your risk of skin cancer is also increasing. Now, what skin cancer should you worry about? Well, again, skin cancer is the most common the most common cancer of any cancer that occurs in transplant patients. The rate is approximately around 100 times that of the general population. Unlike the general population, in which basal cell is the most common skin cancer, in transplant recipients, squamous cell carcinoma is the most common. In fact, in the two patients that are in this renal life flyer, they both developed squamous cell carcinoma. If we stratify the different types of non-melanoma skin cancer that we talked about, you can see that squamous cell carcinoma in general is around 65 times higher in transplant patients versus the general population. Squamous cell carcinoma of the lip, 20 times. Basal cell carcinoma, 10 times. Melanoma, anywhere from 3.5 to around 5 times. And Kaposi sarcoma, around 84 times. If we go back just a little bit, one important thing is most transplant patients will start developing skin cancers at sort of a magic time point around 3 to 5 years after they receive their transplant. Okay, so what are your risk factors for developing skin cancer? Who's at greatest risk? Well, there are a number of different risk factors. The first is if you have a history of skin cancer before transplantation, about 3 out of every 4 of these patients will go on and develop additional skin cancers after the transplant. Being fair-skinned is certainly important. Significant sun exposure, a very important risk factor. The different types of transplant can also relate to the type of, how common skin cancer will develop. Heart or lung tend to develop more skin cancer than kidney transplant patients or than liver transplants. But the condition can be very serious. In fact, the study which brought this whole problem into prominence was around 10 or 15 years ago in Australia, and it showed that about 1 out of every 4 deaths that occurred after a cardiac transplant were actually due to skin cancer. Now, the duration, the intensity, and the type of immunosuppression also makes a difference, and I'll talk a little bit more about that later. And in some studies, having a history of warts or many warts can also be a potential risk factor. Now, sun-damaged skin has this appearance. It has discoloration. You can see these precancers present, and these scaly areas tend to be fixed. So if your skin looks like this, time to get checked out. Next one. And all these little circle areas right there, if we go back one, are all those precancers that we talked about. Okay. Who gets sun-damaged skin? Well, it tends to be the fair-skinned individuals, and the dermatologists actually use what we call a skin scale called Fitzpatrick, and the most fair-skinned individuals are those that have extremely fair skin, always burn, and never tan. And so we have that ranked from 1 to 6. And so certainly those 1 to 2, skin type 1 and 2s are at highest risk. Here's another example of sun-damaged skin. Okay. And another example of sun-damaged skin. All of these patients that we routinely see. So why worry? Well, obviously we worry because we don't want you to develop this. Now, the other reason why we worry is because squamous cell carcinoma, the most common skin cancer that develops in transplant patients, behaves differently in transplant patients than it does in the general population. They tend to grow more rapidly. Multiple cancers can arise simultaneously. They develop in high-risk locations such as the forehead, temple, ear, lip, and genitals. The microscopic growth patterns, or what we see under the microscope, can be more invasive, and so nerves and adjacent structures such as muscle can be involved. And it has a higher recurrence rate. It comes back after treatment more commonly, and even can metastasize, go to other organs or distant organs at a much higher rate than it would normally in the general population. In addition, transplant patients can develop multiple skin cancers. When a transplant recipient develops a single skin cancer, there's around a 25% chance of an additional skin cancer within 1 year. At 3.5 years, that percentage goes up to 50%. So once you've had one and you're a transplant patient, there's a high likelihood of you developing another one. In fact, about 1 in 10 transplant patients will develop more than 5 skin cancers each year. So the greatest fear with squamous cell carcinoma is that it can metastasize, and metastasis can be very, very serious. Squamous cell metastasize only in around 2% of the cases in the general population, but in transplant patients, particularly adults, that number goes up to 5 to 7%, or in pediatric transplants, that number goes up to 13%. When it metastasizes, squamous cell carcinoma has a poor prognosis, and this includes local metastasis to nearby lymph nodes, which is the most common, or distant metastasis, which is the most deadly form. So good news, very good news. Most skin cancers can be completely cured, but the key to success is early detection and treatment and prevention, which is why I'm here today. So this is sort of summarizes the different things that you can do, which includes sun avoidance, wearing hats, covering up, wearing UV protective sunglasses so you can shade, and using sunblock. So sun protection really contains 3 different cornerstones. 1 is the use of sunblock, 2 is sun avoidance, and 3 is sun protective clothing. Okay, go ahead. So sunblock, in general, I recommend at least an SPF 30 sunblock. with both UVA and UVB protection. Now, some of you may have been following the news. Before, dermatologists only thought that UVB radiation in sunlight was important, but as additional studies have been developing, it turns out that UVA is also important. In addition, UVA also has a lot of the consequence for photoaging, wrinkling, and so on and so forth. So now we recommend sunblocks with both UVA and UVB protection, often referred to as broad spectrum. There are a variety of different types of sunblocks. Roughly, they can be broken down into two types, what we call chemical blockers, also known as sunscreens, or physical blockers, what we call sunblocks. The chemical sunscreens work by absorbing the energy of the sun. There are a couple things that chemicals that we often will recommend. For instance, those that contain Parcel 1789, which is a very good protector of UVA, or Mixoryl, an excellent broad-spectrum protection chemical. But chemical sunblocks or sunscreens do have their problems. They can be associated with allergic reactions, rashes, and if you have sensitive skin, they may not be always tolerated. I did bring a couple samples, or some samples today. These contain Parcel 1789, so it's something that you can at least try today before you leave. Physical blockers are the other large category of sunblocks, and these typically contain the elements. If you remember in the 1960s, the lifeguard used to wear the white zinc oxide on his nose. Well, we've gotten high tech, and now we've made these in the very, very small particles that you can hardly see. We either use titanium or zinc, and the benefit of this is that it's a blocker. It's a barrier between your skin and the UV radiation, so the light actually bounces off and never touches your skin. Now, I would encourage people to try either type. A rule of thumb is find the one that you like and that you'll use on an everyday basis. And how to use the sunblock? Well, typically it varies. With sunscreens, you need to apply 20 to 30 minutes before sun exposure. You don't want to forget any of these sun-exposed areas, so people remember their face, but a lot of people will forget the tops of their scalp, the ears, the back of the neck, the legs, the hands. All those sun-exposed areas need to be treated. And the most common problem that people, when they use these, is they don't use enough. And so apply a sufficient coat and reapply, because most sunblocks aren't waterproof, or if they're chemically based, will lose their potency in about 4 hours. Also, as lip cancer can also occur with a higher incidence in transplant patients, a lip balm with sunblock is also helpful. Sun protective clothing is a nice added way of generating sun protection, because unlike sunblock, it won't wash off. Sun protective clothing is long sleeve shirts, pants with tight fabric weave, and there are also special UV protective clothing that are available that you can use, jackets, coats, hats. I actually brought some samples courtesy of Sun Precautions. They're on the back table, and I would certainly encourage you to take a look at them. And each one of you have, or you can pick up a catalog of sun protective clothing as well. You'd be surprised to know that a regular white cotton t-shirt only provides an SPF of around 5. Broad brim hats. I don't like baseball style caps because they don't protect your ears or the back of your neck exactly. Sunglasses, of course, to protect your eyes and around your eyes. And here's an example of very good sun protective clothing. And you can see that you can be stylish. And there are a variety of vendors, and I don't interact with any of these companies directly, but Sun Precautions did provide some samples at the exhibit table. Coolabar, SolarTech, Sundays are all examples of sun protective clothing. There's also a detergent additive that you can put in your laundry as well, called SunGuard. And this will make any clothing that you put the additive in into an SPF 30, and it's good for up to 20 washes. And the phone number is right here in case you want to call, and they'll tell you exactly how to order it. It's 1-866-871-3157. Again, this is a detergent additive that you could put on into your laundry that will make your clothes sun protective for at least an SPF 30. Okay. Sun avoidance, avoiding sun exposure between the peak hours of sun, 10 a.m. to 3 p.m. If you're going to be out in the sun, make sure you're wearing your sunscreen, your sunblock, or your sun protective clothing. Try to seek shades. Now, one common thing, you know, it's cloudy. I don't need to wear my sunblock today. So UVB will go right through clouds, and so I think some people can tell you've had your worst sunburn on a cloudy day when you didn't think you needed your sunblock. Transplant patients, pre-transplant, we don't like tanning beds because this just increases your risk for skin cancer down the line. And remember, you don't need a sunburn to develop enough sun damage to generate skin cancer. So your skin has a memory. It remembers all the sun that you've had, and at some point, in some people, that scale will tip over and you will start developing these precancers or skin cancers. Okay, so how do you detect skin cancers? Should I see a dermatologist? Well, the current recommendations, if you're planning on having a transplant, I would certainly encourage you to get a baseline skin exam. Certainly, if you've had a history of skin cancer and haven't had your transplant yet, again, I gave you the statistics. There's a very high rate of developing additional skin cancers down the line, so I would certainly encourage it. Most pre-transplant patients with a history of skin cancer need at least yearly skin exams. In some cases, if there's a history of melanoma, the transplant team will require you to get clearance from the dermatologist before you can get your transplant. And how about for transplant recipients? Well, there's actually a whole group devoted towards developing criteria for when and when you shouldn't develop or have a skin exam called the International Transplant Skin Cancer Consortium. They came out with a general set of recommendations around 3 years ago. And their current recommendations is that all transplant patients should see a dermatologist at least once per year, and more frequently if there are risk factors or a history of skin cancer. And what I do for my transplant patients is I will generally do a full body skin examination depending on their medical history. I look at the skin from head to toe. I usually will palpate lymph nodes to make sure there aren't any unusual lumps or bumps. In any old skin cancer sites, I re-examine for any signs of reoccurrence, as recurrence is elevated in transplant patients. The published ITSCC guidelines for follow-up intervals, again, depends on your medical history. If you have no history of skin cancer or precancers, a general rule of thumb is once yearly. If you do have precancers, a history of skin cancer, multiple skin cancers, or what we call high-risk skin cancer or melanoma, or even metastatic skin cancer, that interval will shrink. And so this is a rule of thumb. Now, you don't need to write all this down. I will tell you where you can get all this information afterwards. Also, it's certainly encouraged for transplant patients to perform monthly self-skin exams. You look at your skin and see whether anything abnormal has developed. Have a spouse or partner help. Undress, stand in good light, use a mirror or even an additional smaller handheld mirror to see the areas that are difficult to see, back, legs, or scalp, and check all your skin. Even areas which don't get skin, as I mentioned, genital skin cancer is also elevated in transplant patients, so that's a possibility. What you're looking for on new or unusual freckles, moles, crusted lesions, in particular sores that don't heal. As I mentioned, a lot of basal cell carcinomas, people say pimples that haven't gone away. You know your skin better than the dermatologist or your regular doctor, and so if you see anything unusual, you'll be able to recognize it sooner. And certainly if you see something that's been persistent, abnormal, crusting, bleeding, non-healing sores, certainly reason to get these evaluated.